The exocrine functions of the pancreas are to secrete enzymes that digest our food for starches, proteins, and fats. And the enzymes are usually secreted in an inactive form and released into the small intestine and then are activated to digest the food that you've ingested. What happens with pancreatitis is there is either early activation of those enzymes or there's a blockage in the pancreatic duct, so the enzymes flow back into the pancreas, activate, and then they start digesting and inflaming the pancreas so that you have a non-bacterial inflammation of the pancreas. Patients with acute pancreatitis often have a history of recent abdominal surgeries or procedures like ERCPs, viral infections, medications, history of alcoholism, history of pancreatitis, or biliary tract disease. They usually present with sharp, sudden onset of left upper quadrant or epigastric pain that frequently radiates to the back, the flank, or the shoulder on the left side. They have tenderness, rigidity, guarding, nausea, vomiting, absent or decreased bowel sounds, or ascites. They can also develop a bluish-gray discoloration around the umbilicus, like there is on this slide, which is called Cullen's sign, or that same discoloration in the flank area, which is known as Turner's sign. Their position of comfort is often either in the fetal position or sitting upright and bending forward. The diagnostic tests that we'll be doing for pancreatitis are amylase and lipase, which will be elevated. You may see elevated bilirubin, ALK-Phos or ALTs, and elevated WBCs and glucose levels because of the damage to the pancreatic cells. Radiographic tests would include abdominal or chest x-rays, CAT scans with contrast, ultrasounds, and MRIs. Respiratory support is going to be a priority in the initial phases of acute pancreatitis. This patient is going to be at risk for sepsis, SIRS, and then ARDS. They also have poor respiratory effort because of the pain that they're experiencing. Acute pain is our secondary problem. We need to reduce the pain with interventions that will decrease GI tract activity. If we put food into the stomach, that will stimulate the excretion of pancreatic enzymes and increase the pain. So the patient is going to be NPO. They may have an NG tube. They will have IV fluids with calcium and magnesium replacement if needed. Surgical treatments will be a lap chole if there is biliary obstruction, or surgery to drain abscesses and cysts if they are present. Chronic pancreatitis is progressive and destructive with inflammation, fibrotic changes in the pancreas, characterized by remissions and exacerbations. They can be caused by previous acute episodes of pancreatitis. It can be alcohol-induced, chronic obstructive, or unknown etiology. The assessment of chronic pancreatitis will show a dull, nagging pain rather than the sharp acute pain of acute pancreatitis in the left upper quadrant, vomiting, weight loss, steatorrhea or clay-colored stools, jaundice, and elevated glucose. Diagnostically, we can assess the situation with an ERCP, an MRI, a CAT scan, or by fecal analysis. Our goals are pain control, adequate nutritional intake, and prevent relapses or exacerbations. So our non-surgical treatment is going to be NPO status, IVs, TPN, analgesics, enzyme replacement, insulin for the elevated glucose, PPIs or histamine antagonists to reduce acid production. Surgical treatments are going to be drainage, pancreaticojejunostomy or the Roux-en-Y procedure, which joins the pancreatic duct to the jejunum, or a radical procedure called the Whipple procedure, where we remove the head of the pancreas, duodenum, part of the jejunum, a partial or total gastrectomy, and a cholecystectomy. There is no cure for chronic pancreatitis.